Hey everyone. I hope those of you who celebrate Christmas, Hanukkah, or Kwanzaa had or are having a wonderful holiday. I was honestly not planning on posting another video in 2024, and I particularly did not want to jump on the social media bandwagon to post my take on health insurance in America. Luigi, he's a little old news at this point, but I did recently see two seemingly unrelated social media posts that have highlighted a peripherally related issue about medical insurance, one that many people misunderstand. It is not that the health insurance industry in America is a total disaster. We all understand that very well. But it concerns one aspect of how to fix it. The first post was by California Congressman Ro Khanna. I respect and generally agree with Representative Khanna. His district neighbor's mine, and randomly he graduated the same year as me from our rival high school back in Pennsylvania. So I do feel a sort of kinship with him. But earlier this month, he posted something on Blue Sky that is a truly terrible idea. Who supports a simple law requiring insurance companies to pay for medicines or treatment prescribed by a doctor? Something we could do now while we fight for Medicare for all. A little while later, I came across this Reddit post, which was spreading a viral image from another platform. It's allegedly a denial of service letter from an insurance company, though the writing style is bizarrely stilted and sounds like it could have been written by a bot. You were admitted to the hospital on 11/29, 2024. The reason is blood clot to lung. We read the medical records given to us. This stay does not meet the guidelines. You were stable. You had tests that did not show any problems that needed inpatient only treatment. Your blood pressure was not too low. You could have gotten the care you needed without being admitted inpatient at the hospital. The hospital inpatient admission is not covered. The Reddit post received 27,000 upvotes. It was similarly popular on Twitter and Blue Sky. Here's a few representative of the 1,600 comments it received on Reddit. Right-wingers can bitch and moan all they want about the wait times in Canada for healthcare, but if I had a fucking pulmonary embolism, I know I'd get the needed care. This is why a lot of hospitals now have denial of claim specialists whose job it is to fight on behalf of the doctors and patients to overturn these kinds of ridiculously egregious denials. And you were in the hospital to observe if something went wrong. Nothing went wrong, ergo the hospital stay was not needed. Claim denied. Is some mental gymnastics. It would be funny if it wasn't so horrible. As I already stated, the American healthcare system and the healthcare insurance industry is an absolute disaster. These are facts, they are not debatable. But here's the thing that many laypersons and apparently politicians don't understand. Frontline physicians and other clinicians, we cannot be the sole arbiters of what medical care, insurance, or the government is required to pay for. If we were to adopt a system like Khanna suggests, where anything the doctor prescribed would be covered, this system would immediately be bankrupted. Frontline physicians, that is, the people who are actually seeing the patients in the clinics, ERs, ORs, and hospital rooms, we are terrible at making cost-effective decisions when left on our own. And that's for a number of reasons. First, we don't have any easier access to the cost of things than patients do. I have a rough idea of the out-of-pocket cost of some common lab tests and radiographic studies at my hospital. But if you ask me for the cost of a liver biopsy or for 6 weeks of Zosyn by home infusion, no idea. I could, if absolutely necessary, contact the hospital's billing department and request the out-of-pocket cost for a particular treatment, and maybe in a day or two, I'd get back an estimate of the dollar amount attached with a long list of caveats. But that's completely impractical to do every time I order something. I wish we had a user-friendly, searchable list of meds, tests, and procedures that could tell you how much each thing would cost the patient given their insurance, but I have never heard of something like that existing in the US. Second, clinicians tend to overestimate the effectiveness of treatments. Medications that we think are very effective are often only modestly effective, while medications that we think are only modestly effective are often not effective at all. The typical patient who is admitted to my service in the hospital might arrive on 10 different outpatient meds, of which 2 or 3 are probably no better than placebo, while another 2 to 4 are sort of justifiable but are unlikely to actually make a difference to that particular patient's health in the long run. We also overestimate the discriminatory power of diagnostic testing, meaning that we conclude that a positive test result means the patient is more likely to have the disease in question than they really do, and that a negative test result means the patient is less likely to have the disease than they really do. In short, we are biased against uncertainty. The reason this is relevant to this discussion is that uncertainty in the diagnosis makes a treatment less effective than if the diagnosis was certain, because, of course, the treatment is not going to work if it's not aimed at the correct diagnosis. And if a given treatment is less effective, that means it's necessarily less cost effective. So, by physicians systematically overestimating the certainty of diagnoses, we systematically overestimate the cost effectiveness of treatments for those diagnoses. The next reason frontline physicians in America err on the side of excessively costly care: fear of malpractice lawsuits, also known as CYA or cover your ass medicine. We order expensive tests for diseases that a patient is highly unlikely to have because even if a decision to forgo a test is justifiable based on statistics and the medical literature, if the patient actually ends up receiving that diagnosis down the road, we could find ourselves getting sued. The bar for committing malpractice in the US is whether one fails to deliver the so-called standard of care. The standard of care doesn't refer to guidelines or the scientific literature, but instead refers to what other clinicians in your community would have done in a similar situation. So, if your colleagues tend to overorder tests, fear of malpractice lawsuits incentivizes you to err on overordering tests too. And malpractice fear doesn't just impact overordering tests, it can also lead to erring too much on the side of admitting a patient. For example, let's consider the patient on Reddit with the acute pulmonary embolism or the blood clot in the lung. If that patient was not admitted from the ER for observation for a newly diagnosed PE, and instead went home and died at home, you can very easily imagine that physician getting sued. That describes a lawsuit that's happened countless times before. But what if that patient was young, previously healthy, and their PE was so stable that hospital admission for observation was objectively unnecessary? If the ER physician decides to admit them to the hospital anyway, and the patient picks up a severe hospital-acquired infection and subsequently dies from that, what's the likelihood that the ER physician gets sued in that situation? Gets sued for unnecessarily admitting the patient? I would guess that it's approximately zero. In short, fear of malpractice contributes to unnecessary admissions. Next, while physicians do not receive literal kickbacks from prescribing expensive medications or medical devices as sometimes claimed on social media, they can be swayed by marketing and by visits from drug and device reps. Now, this issue is not nearly as big a problem now as it was when I started in medicine 20 years ago, but it's not trivial either. We lay that some physicians order or recommend things based on personal incentives. At a previous hospital where I worked, there was this one neurology consultant who, for literally every consult she received, she recommended an EEG. The consult could be for myasthenia gravis, and she would recommend an EEG. And I was so perplexed by it until I learned that she was the sole person responsible for reading the hospital's EEGs. Most of us are above providing excessive care for the purpose of increasing our own income, but it does happen. And there were plenty of examples of this during the COVID pandemic, with unscrupulous physicians opening what amounted to little more than ivermectin clinics. Or currently, wellness doctors who sell supplements and pseudoscientific therapies directly out of their own offices. Can you imagine what would happen if the government was required to cover outpatient vitamin infusions for the worried well? And what about classic alternative medicine quackery? A holistic doctor who prescribes acupuncture for high blood pressure, or homeopathy for pretty much anything. Those businesses would thrive in a model in which everything must be covered because the doctor knows best. And last, physicians often acquiesce to patient requests or sometimes patient demands for non-indicated tests and procedures because it's easier and quicker than explaining why those tests and procedures are not indicated. Now, maybe it doesn't feel this way to some of you watching because you've personally experienced a situation in which your own physician declined to order something that you thought was indicated. In your specific situation, maybe you were right and the physician was wrong. That does happen. But more often than not, the physician is correct. After all, why would the physician deny you a test that's indicated? What is the incentive to do that? It's not like the insurance company is going to reward the physician for saving them money. That's not a thing that happens. It's so much easier and less time consuming to just give in to patient requests as long as they're not so egregious as to result in overt catastrophe. So just to consider that for every time a physician declines to order a test that the patient thought was indicated, they probably ordered 10 non-indicated tests because the clinic schedule only affords so much time to have that discussion. For me in the hospital, the most relevant situation is when a patient is well enough to be discharged, but they insist on staying another night or two for additional observation or for peace of mind. Some physicians respectfully say something like, I'm sorry you disagree, but you're being discharged anyway, after which the patient could formally appeal the discharge, which they almost always lose. But other physicians don't want to deal with the hassle and energy it takes to go through that process, and they want the patient to feel listened to and respected. Sometimes it boils down to who is it easier to argue with, the patient or the hospital's case manager. So, in the end, some patients stay longer unnecessarily at a significant cost to the healthcare system. So, where am I going with this? The point is that physicians, if left to make their decisions unimpeded by any gatekeepers of care, will order more tests, more procedures, more medications, and more hospital admissions, which will collectively be less effective and more expensive. Now, that gatekeeper should definitely not be an insurance company clerk with no personal medical training. But there needs to be somebody knowledgeable, objective, and free from profit-driven incentives who is able to make these decisions. Otherwise, every dollar that America saves by eliminating insurance industry bloat will be offset by $2 spent on non-cost-effective care. I also don't want to make this only about cost. A lot of unnecessary care that patients and physicians would order in the absence of gatekeepers does not just have an unfavorable ratio of benefit to cost, it also has an unfavorable ratio of benefit to harm. In other words, it's dangerous to order unnecessary antibiotics, non-indicated scans, and inappropriate hospital admissions. It also slows down the system for sicker patients. Wait times for tests and procedures will grow far longer if insurance companies or the government was suddenly required to pay for everything regardless of appropriateness. And this will hurt those patients who actually do need these things. Which brings me back to the Reddit post about the pulmonary embolism hospitalization. The universal response from laypersons to the Reddit post, as well as to other posts about that specific denial letter on other social media platforms, assumed the hospitalization was justified. How could it not be? A blood clot in the lungs sounds serious. People die from that. In med school, a pulmonary embolism is often labeled a so-called don't miss diagnosis. But as any physician who routinely diagnoses and treats pulmonary embolisms can tell you, there are some patients, the minority patients, but there are some patients who present to the ER with an acute PE who actually are appropriate for discharge home from the ER on an oral anticoagulant. That's because of their age, a lack of significant medical comorbidities, normal exam, and normal tests indicate that that person has excellent prognosis. And this is not just based on Gestalt. There are validated prediction models or clinical prediction rules that can be used, like the PE Severity Index. So while we have no idea if the individual specific person who received that specific denial letter should or should not have been admitted to the hospital for their PE, the thousands of laypersons who assumed that the insurance company must have been in the wrong were themselves incorrect. It's even possible that the admitting doctor knew the patient didn't require hospitalization, but admitted them at the patient's insistence or because they were afraid of the tiny risk of a malpractice lawsuit. All this is to say that patients are not able to judge what care is or isn't effective. Every insurance company horror story that you come across online is not what it seems. Some denials are appropriate. From time to time, I receive notices from insurance companies that the final 1 or 2 days of one of my patient's hospital stays were denied coverage. In almost every one of these cases, the patient was one to whom I had recommended discharge on a particular day because it was the medically appropriate thing to do, but the patient insisted on staying longer despite my explicit warning that the extra day might not get covered. I suspect that many of those patients feel like they've been victimized by the medical insurance industry, and some may have even posted about their experience on social media. Again, this is definitely not a defense of the medical insurance industry in America. It's just that not every viral story about them is what it seems. In conclusion, modern medical care in the US is complex and very expensive. Patients in America are researching their symptoms and diseases more than ever before. And while it's generally great to have informed and empowered patients, the consequence is that patients are asking for more and more things that are not always indicated. This includes large panels of expensive blood tests, MRIs and CT scans, the latter of which non-trivially increases cancer risk, prolongation of hospital stays, unnecessary subspecialty consults, and a whole collection of pseudoscientific quackery. The medical insurance industry is absolutely horrific and needs to be overhauled or ideally replaced entirely, but we cannot adopt an alternative in which physicians order whatever patients request, or whatever was requested is necessarily paid for by the government. There needs to be an independent, objective arbiter of what care is sufficiently cost-effective to be covered. If it isn't the insurance companies, it will need to be the government. Otherwise, the whole system is going to fall apart. Anyway, on that uplifting note, I wish all of you a happy new year, and here's hoping that 2025 is not a total disaster.